What we were trying to do in the first section is to lay out Edson's model and develop something that we could use as a group moving forward. What we'd like to do in the next segment is to look at some of the assumptions and to have you kick the tires of our assumptions and give us some feedback about what we need to be adding. And we'd like to do this in a small group techniques. The first 20 minutes or so will be the guiding principles, and then we'll talk about the actors. And so we'd like you to work in your tables. If you could move to the next slide. This is our overall model where we're asking whether and how the health labor market mediates the translation of population health needs to the actual health professions, workforce, and career choices. So the first topic for input and discussion will be the guiding principles. And the question is that if we are going to develop an approach to financing health professions education, what are our foundational principles? And the one-pager and Aaron have gone over each of those, but that it's responsive to society's needs, that it is transparent as possible, that it is nimble, that it actually generates value to the actors in the system and the system itself, that it be not just limited to the first phase of education, but extend over the lifetime, that it be just in its organization, and that there be interconnection between the education sector, the government sector, the health system, that it be a one world theory, if you will. So what we'd like is your input about these. Have we missed some? We're sure we have. What would you add? And what I'm going to do is give your groups 7 minutes to have concentrated, pithy, succinct discussions. And then, since we're being very generous with time, 13 minutes to share those across the group. And we have note-taking. We will integrate these into the model as it develops across the day. Does that make sense? Great. So the first question is, these guiding principles, are they right? Are there any elements you'd add to them? Are there things that we need to keep in mind as we think about developing a system of the future financing of health professions education? So we're off. So there's a number of people who are in the gallery back here, our guests. What we'd like to do, both for this and the following sessions, is for you to form your own group, talk with each other, and when we get later on, we'll have you vote as well. So if you can talk in that group, that would be great. All right, colleagues, we'd like to move ahead. We apologize for limiting your conversation, but we want to make it a larger group conversation. And I'd like to hear a volunteer to begin with. How are we with this set of assumptions? What would you, I'd like a comment from a floor. Thank you. I've got the Malcolm Cox wandering facilitator. Um, so, great. Sir.
So I think, I mean, a lot of these principles are like, no, we don't want to be transparent, you know. I don't think there's a lot of opposition to
Motherhood and apple pie, yeah.
So, and as we said, the devil is always in the details on how these things actually work out. But the first one is a good example. You can pretty much drive a truck through that one. But it's I think, framed a little bit too passively. It ought to be responsive to and engaged with society in determining need, if you will. The point being is that, as we heard earlier today, when it comes to the healthcare exchange process, people don't necessarily know what they don't know, and they don't know what they need. And so I think part of this engagement has to be part of that concept of being responsive.
Excellent. Other thoughts? Joanne.
Staying on that point, responsive to society, maybe we just didn't get further because we got stuck there. But our table spent quite a bit of time discussing the question of, well, what does society want? And that in some countries or health systems, there's an assumption that health care is a right, which then drives perhaps your guiding principles slightly differently than if you assume that health care is not necessarily a right and it's a business model. And what are you being responsive to? And then, you know, of course, you could go into a whole digression that ends with world peace.
And in the middle of an election season, how do you figure that out? Yes.
Don't even get me started.
So Table 7 had two big things we talked about, similar to this is one around cost. We should be looking at the provider that provides the function at the least cost. So again, responding to society's needs in a way where it is, the economic base is not using a high valued provider like a doc when you can use a registered nurse or something like that.
So it is both, is there both cost and efficiency there? Or?
Yes.
Yeah.
Yes, and then the second one thing we didn't see on there is could be part of interconnected, is interprofessional practice and thinking about the fact that the system is changing around us and it's going to be team-based models of care.
So whatever we do needs to incorporate incentives for that.
Yes.
Excellent. Good. Other thoughts?
Did I miss anything?
Sorry.
So we had an action-packed 7 minutes. We have three.
I'll have you know that it was actually 8 minutes.
Fair enough. That'll justify. So there were three particular comments. One is, interestingly, we had the same reflection that responsive appeared passive. It seems like a passive phrase. So we thought to convert that into perhaps accountable to society as a suggestion for another phrase. One other comment was, what was perhaps missing is representative of the diversity in the community or society, that the workforce that's being trained should reflect rural, demographic, however you define diversity of the community should be reflected in the workforce that's produced. And the third comment was flexibility in the system should be a key, flexibility, dynamic.
What do you mean by flexibility?
Do you want to elaborate on that?
Sometimes the language we use suggests that we're going for a thing in a place of time. And actually, if you believe that there's constant change, then the concept that a system has to be malleable to constantly changing and evolving was probably the focus of the comment.
So it isn't just nimbleness, which is speed of response. It is
exactly.
also flexibility of response.
Yeah, and actually, we talked about that distinction as well.
Okay, good. And is that also one size doesn't fit all, and the rare awareness that one
Yes.
size shouldn't fit all?
Yes,
Given where different communities are in their evolution and different
correct.
kind of needs of regions. Susan.
Yeah, I think at the community level, also agreeing with everything that's been said so far, talking about how you determine what the need and the demand is. And I think that's where you make a distinction between community members, and there's a whole issue with defining who speaks for the community. You know, in LA, we thought it would be one group, it turned out to be 70. So you have to look at that individual level, but then I think something like social determinants of health and all of the work that's done in public health on what we in public health call population health, not what there are two population healths now, that all of that work gives us a 30,000-foot level, if you will, and that we really need both. We need the grassroots, and then we need the overarching analytics to be able to look at that, because as somebody just said, people don't always, I think it was John, people don't always know what they want. So we need to do both, because there are a lot of things people do know.
So is there a distinction that you would make between society, which is one of this other group? How do we know what society wants, and how would we know what a local community wants? Or
I think that in answering the question of how we know what society wants, you need to do both. You need to look at local community, and you need to do the overarching macro understanding.
Excellent. Joanne.
Two other words that got put out in our group were sustainable. That was the first thing as a principle for financing. And access, and that got discussed a little bit in the kind of going back to the access to health services, but also the accessibility of the education, which I think is related to kind of who is getting educated in terms of reflecting your society.
Now, just to go down the level of sustainable, one of the questions I'd like actually Mr. Edson to speak to, Dr. Edson, sustainable in the context of healthcare or in the context of overall healthcare? An issue is to what extent does healthcare and the economy of healthcare either support or suck away resources from the rest of the economy? And I was wondering whether you could comment on that, Edson.
Yep. Thanks, Roy. I think that's one of the things I didn't put in the presentation because I was focusing more on the education, but certainly there's one of the areas that had some work recently. As I mentioned in the presentation, there was a UN Commission on Health Sector Employment and Economic Growth that deals with these issues. But going back to your question is, the discourse for a long time from macroeconomic perspective is that services sectors, not only in health, but health and education, they absorb productivity growth in other sectors of the economy. You know? Basically, it's like, say, manufacturing, they increase in the productivity, and the salaries goes up. And the service sector, they don't increase productivity as much, but they keep the same rate of increase in wages. So basically, the wages grow at the same rate of the rest of the economy, but the productivity doesn't grow as much. And then that comes the argument that's well known by the cost disease argument, you know, by William Baumol, you know, Nobel Prize in Economics, saying that in the long term, service society is going to absorb the results of the economy and going to be bad for economic growth. You know? But again, it's not only health, but health and education. So from one side, if you look at the wages, yeah, wages in healthcare increases, and I show some of the increase compared to other professions. However, some new evidence have shown that's not necessarily the case, right? And then you have, I can cite 3 reports at least. One is the Investing in Health, the World Development Report 1993, the UN Commission that just being released, and also the World Bank in 2013 released a report showing that it's not necessarily the case when you look at the, like say, worldwide. Last point is, of course, there might be some limit, no? Like say, if you look at the US, for instance, you spend 70% of GDP in healthcare, probably in some of those extreme, probably there is some impacts, negative impacts on the economy. Right?
So when you were talking about sustainability, Joanne, were you talking about programs themselves or the macro? I mean, both are probably important.
So I think we were challenged to think about healthcare education not in the next 3 years or 5 years, but we've been challenged to think about it in 30 years or a Carnegie report of 100 years. So we can think of a system which is responsive and transparent and nimble and not sustainable, and then we haven't done our job. So we need to think of all of this and package it in a way that we can present it to our society in a way that 30 years from now, the work we do here, in fact, results in a system which is transparent and nimble and equitable and diverse and still exists 30 years from now.
Which actually raises another issue, which is most strategic planning has an embedded time frame. What's the right time frame for us? Is it 5 years from now? Is it 30 years from now? Is it 10 to 15 years? What makes sense for us? You don't have to answer the question, but there and there.
Question. But it should be long. Listening to this conversation, and I think this was brought up before, I keep going back to the social return on investment, and is that the sustainability part? If we have high social return on investment, are we going to have a more sustainable system because it's going to be responsive at both sides of the model?
Good way of framing that. Sir, just one or two more comments after that.
Yes, as an educator, we've always looked at 40, 45 years, lifespan of the professionals we're training them. So to try to think about how they're going to evolve, and then if you're one of those people who have lived those 40 years, you can look back and see the changes. So I think that's at least the parameters we've always used in preparing people at our school.
There's a group in Cincinnati that asked that question as they think about all the health resources. What they said is, this is a planning group for the region of Cincinnati. They said, well, we should be thinking about what will happen when the children in our newborn nurseries are old. So it was a 70 or 80 year, and it really does change your perspective about sustainability at that level. Any final comments? Really good feedback. Thank you very much. And I'm sure there'll be other thoughts as we come forward, as we try to flesh out this model. If you could go to the next slide, please, Megan. So we were not born yesterday, we in the planning committee, and we do realize that there are human agents and human institutions that will have to gain and to lose from any changes in health profession financing. We wanted your help in trying to underscore who are the actors, if you will, who we need to think of as we think of our health professions education financing. So this is the list that we came up with. This was in your one pager. So those would be the learners, the employers, the education system, the health system, the government taxpayers, and there may be a distinction between those, communities, regulatory bodies, and the professional associations as we move forward. We'd like you to think about that list, make points of emphasis that you did just now, but also any you would add to the list. And you've got 7 minutes to do that in your groups. Thank you. Why don't we bring the conversations to close? I have good news from the pre-election polling. The straw votes are in, people are voting, and there's lots of additions to this list. So open it up to anybody who'd like to be brave and bold and start. We'll start over here, and then we'll go to there. Rob.
Okay, our table it wants to add commercial lenders, philanthropists, and policymakers. It's sort of government payers, but we feel like the policymakers can really influence how the government, how payments are for loan repayment, other kinds of things, so.
Great.
Is that
I think we'll say one suggestion per group moving forward, but that's a great additions. Yeah.
Build on that. We looked at the government payers, we thought it's really a category of payers, and then there's subcategories. So what was the mention was one of subcategories, but there are also not-for-profit and for-profit health insurers who are financing
Not just
education.
government, yeah.
So I would do payers and then government, taxpayers, et cetera, and go down that list. We talked about that.
Yeah, no, another term for what we're, oh, I'm sorry, Rob. So, Rob.
Right, we just got a paranoid table that I've not said anything yet. So, picking one, I'm going to pick yours, which is within the heading of the health schools, actually differentiating the faculty and members of those schools as opposed to the leadership, because they've got a different set of drivers and personal investment.
And say patients too before someone
Yeah,
else
so
does.
patients are separated out from community. We did a bit of separating out within some of these broader headings.
Which is, I think, one of the lessons that I heard several groups talking about, which is it isn't so simple to say government payers and policymakers. It isn't so simple to say education. There's actually, it's a complex system within a system.
We've got half a dozen others, but we'll let people play.
Your comment about patients made me realize that having done a fair amount of work in this forum and elsewhere around patients, the fact that we didn't include that up here, mea culpa. Joanne, and then over to here.
We also were a table that talked about disaggregation, the observation of the community being 70 communities plus what a patient needs at the time that they're sick and in crisis is different than what a community might say in theory they need. Education having a huge range from the private for-profit colleges all the way through, the faith-based programs through Harvard, which all have different influences on the system. Policymakers was brought up, and we actually brought up the term of political players, which aren't necessarily the same thing as policymakers, and the optics of politics can be different.
Can you give an example of that?
Scott Walker has been brought up here a few times. But really, what you will hear somebody say in a political forum can have an influence over our guiding principles and potential, and that may be distinct from what a policymaker at HRSA might, or in a government agency might actually have in mind, and those are not
What they say in the primary season may be different than what they say in the main season.
Oh, and don't even get us going about our election in this country. It also was touched on at the very end the importance of thinking in an international context, that learners are often crossing international boundaries to pursue education. Employers may be looking at international placements of their next facilities and what the health resources are of where they're going to put their new plant or the financing system associated with that. And employers also have roles sometimes in funding education of their workers, whether you're a healthcare employer or a non-healthcare employer, and in funding the delivery of healthcare, again, as an employer or as a healthcare system.
And as those different states and employers compete against each other, they will adjust things.
Yes, yeah. So it's a giant disaggregate everything.
Yeah, great. Mary Beth.
So to add to the list, we sort of broke down the employers a little bit. We talked about big pharma and other big health medical device agencies. It's both because the learners are getting cues, the health workers are getting cues, and they drive the system quite a bit. We talked about lobbyists, or sort of the breakdown on one of these other categories here, and broke out DOD and VA as big healthcare systems that sort of cross many of these. And we actually talked about the individual versus the patient. You know, they have co-pays, they go to CVS, so they have so many influences on what they absorb from our, you know, system of health.
Great. Yes, ma'am.
I think it's on now. Our group talked about following the theme of the patient, individual. We really talked about that, and we landed on the public. And the reason why we landed on the public as an actor is that we wanted to move away from sort of the disease-based approach and be inclusive of those people that are healthy. And so that's our one actor that we came up with. We talked about other things, but since you requested one, we'll stick to one.
But it's the key to the success of the ACA is the public participation beyond the sick participation. Yeah, great. Saray.
So we also unpacked many, but the two that I will highlight here, one is potential learners or future learners, including, and in addition to the existing learners. And the other is just to second what Susan was saying in terms of unpacking the payers. We talked about investors, meaning entrepreneurs and impact investors and other types of investors, in addition to those who lend, in addition to the insurance companies who also pay in different forms. But I thought that investors category was an important one. We had many others, but I think they've been mentioned.
So the about to be learners, are we getting at the issue of which people do we want to get into healthcare? Your admissions point from earlier, is that your sense?
Exactly that. And from a global perspective, so important
Yeah.
as well.
Right. Good. Other suggestions? Rob.
So when people were talking about pharma under employers, when we were talking about employers, we thought you were talking about employers of health professionals and their leverage. Whereas a colleague said, what about the wider business community and their reliance on the health system? And the example was like when GM went north to Canada. So have they got a valid stake in this conversation? I think
Right.
Was there anything else? Oh, families of learners. So the fact that learners don't fund themselves a lot of the time, there is a wider family community that might be part of that mix.
Yeah, so in the United States, as we've seen the explosion of student debt, it is really, in some ways, it's Reaganite policy with Obamaite budgets. And what that's meant is a proliferation of gorgeous student facilities to attract the parents who are paying for the education. Yeah.
Another example, sort of unpacking the community, because we actually said there's community, there's family, and then there's the individual. But I think there's these other things I'm thinking of in Tajikistan. There's these community-based health financing actors.
Local cooperatives.
Cooperatives, right,
Yeah.
that even are beyond that.
Great. Yes, Bjork.
Just to add to the international perspective, you know, and Chita just mentioned that during the discussion, is that there's proliferation of private school, medical schools or nursing schools that are really, you know, when you don't have strong regulatory systems, they're actually driving, creating, you know, it's an economic focus, which I think actually is the same thing here, like you were talking about, you know, there's a drive to focus on needs of students, but not necessarily learning needs, but, you know, nice gyms, nice facilities. So I think, you know, this influence is something that we should be thinking about very closely.
Which is another way of that unpacking the education of who do we mean by education, and the other forces are there. Great. I'm very disappointed in the group because you've listed us too many things to put on one slide. But I think there's a number of patterns that I'm seeing here. One, the need of getting beyond the superficial phrase and disaggregation, really thinking about who are the stakeholders for each of these. And then there's a lot of specific categories of philanthropy, patients, and some others that people have raised. Any final suggestions or comments? Yes. Sorry, you're too close.
Well, I also wonder if the actors can't be divided into those. and really move the needle versus those whose input is critical to the moving of that needle to get where we want to go. And I don't know how exactly you do that.
So which actors have juice?
Kind of, yeah, binoculars, yes. I mean, because, you know, we can create a utopia, but if we can't get it done, then it's an intellectual exercise that's not going to help health and healthcare. And so,
Yeah, and the danger is if you work only with the people who have clout.
no,
It's the problem. I mean, that's the danger.
yeah, it's the danger.
Yeah. Good. Other comments? Thank you.
I just think it's important to know whether this is going to ultimately be an internal document or external document. And the reason I say that is how we might frame something versus how the people who might read it and how it might get circulated are very different. And so we talked about that a little bit here. I just think it's important both for this one and the other one to be aware of who is the audience. I mean, we can create it for an external audience and then we can say what we mean by it, but it's always important to determine who's going to be looking at it.
That's a really good thought, and I think it's for us important to keep track of who our audience is. I'm also personally thinking about beginning to publish under pseudonyms, which has been done at other times in history, right, for very similar reasons. So now you have 30 seconds to breathe before we come out and try to encourage you to your civic duty. If Patricia and Ann could come up here, please.